Hi, everyone. I'm Dr. Morayani. I'm the director of the Johns Hopkins Multidisciplinary Recurrent Pregnancy Loss Center. And today we will be talking about hopefully how we can navigate the path towards a healthy pregnancy in the setting of recurrent pregnancy loss. So we already went this information, and I want to start by welcoming everyone. I know that if you have experienced pregnancy loss, or more specifically recurrent pregnancy loss, this has not been an easy path for you. And I am very sorry for what you've been through. But at the same time, I want this informational session in your care at Hopkins, should you choose to have care here, to be a very welcoming experience where hopefully we can address your questions, your concerns, and tailor care to what makes most sense for you and your partner if you have one. So let me start with something very basic. Recurrent pregnancy loss can be abbreviated as RPL, so I'll be using these terms interchangeably during this presentation. And we will be talking about what is RPL, what causes it, how is it diagnosed, and how can it be treated. And I would like us to start by keeping in mind a couple of things. First of all, this is a little bit, a few of the areas we'll be discussing are very gray areas, as I like to describe them, meaning there isn't a right or wrong answer or very strong data supporting one approach versus another. But as this field is progressing and we're learning more about what RPL is and its different factors affecting it, we are gaining more knowledge in each one of these categories. I also want us to start with kind of a Mythbusters section, talking about things that we may think are true, but are truly not the case when it comes to RPL. And I think it is very important to keep this in mind throughout this presentation. And that's probably one of my most important slides today. More importantly, very important to remember, this is not your fault. Everyday stress or physical activity rarely causes miscarriage. You are not alone in this process, as we'll talk about. This is unfortunately very common, but there is hope, which is hopefully the positive message that will come out of this presentation. Okay, so how is RPL defined? What does it mean to have RPL? RPL refers to 2 or more pregnancy losses, and I'm purposefully keeping it vague because a pregnancy loss can be defined as a miscarriage for which you require medical or surgical treatment, or a biochemical pregnancy, meaning a very early pregnancy where all we are able to monitor are blood hormone levels increasing, but then unfortunately eventually decreasing in pregnancy. Those losses can be consecutive, meaning one after another, or they can be separated by healthy pregnancies in between or before or after them. And as I mentioned already, it is much more common than many people realize. And unfortunately, if you have experienced pregnancy loss yourself, maybe before you had a pregnancy loss yourself, you thought you were the only person who had ever had a miscarriage. But as soon as you start sharing, maybe with friends or family members, then more and more people start saying, oh, that's right, I had a loss too that I wasn't comfortable talking about, or I had tried to forget, or was so long ago that I have since built my desired family and I don't talk about it anymore. And exactly how common is pregnancy loss? We believe that up to 15 to 20% of all clinically recognized pregnancies end in miscarriage. And if we were to even go before clinically recognized pregnancies, obviously data is harder to collect there, but about half, 50% of all pregnancies end even before the clinical stage. So either as a biochemical loss or as an early implantation failure. So this is for a single miscarriage. About 2 to 5% of individuals or couples will actually experience recurrent pregnancy loss, as we talked about 2 or more pregnancy losses. and 2 consecutive losses are about 5%, and 3 consecutive losses are about 1%. And if you are looking at these percentages and thinking, oh, wow, I am in the 1%, let me frame this in the context of the data is derived from earlier studies where the definition of RPL was much more stringent, meaning it was defined, RPL was defined as 3 or more consecutive miscarriages. So it is possible, it is actually, it is known that these percentages are significantly underrepresenting the percentage of people who are experiencing these losses. So what are some possible causes of RPL? And I think we are all probably familiar with the possibility of genetic causes. Okay, and I'm referring to chromosomal abnormalities that can be seen in either the parents, meaning the egg and the sperm source, or the embryos themselves. So if we think about it, we all have DNA in every cell in our body, and there's also half of that DNA or half of that chromosomal makeup in the eggs or the sperm. So that together they make, again, a new embryo or a human being with the full complement of chromosomes. So it's either that the majority or all of the cells in the egg source or the sperm source have a chromosomal rearrangement, and that can be diagnosed through karyotype testing of the male or female in the relationship. And the most common type of abnormality in parents is a balanced translocation, if one is to be found. It's found in about 2 to 5% of RPL cases. But that is not extremely common. What is more common is that all of the cells in our body carry the correct complement of chromosomes, but either the eggs or the sperm carry and for the first time have a rearrangement in the chromosomes, and that can lead for the first time in the embryo a misarrangement or a mismatch known as an aneuploidy, and a common type of that is trisomy, so an extra chromosome number, whatever, any one of the chromosomes being extra, and it's about 75% of the cases where chromosomal abnormality is found, it is due to a trisomy. How do chromosomal abnormalities happen in embryos? The most common question I think that most of us may be familiar with, or the most common answer most of us may be familiar with, would be that it is related to the age of the egg. And in this diagram, if we look at the green line, that represents miscarriage rate, as the age of the egg increases, the risk of pregnancy loss increases as well. And so as one gets into their mid-30s and late 30s and 40s, the risk of a miscarriage significantly increases. So eggs are definitely important, but it is also extremely important to acknowledge sperm contribution to pregnancy loss and RPL. Age of sperm is extremely important as well, but probably less well studied or understood. And also another component to consider here is increased risk of DNA fragmentation related to age or otherwise in sperm can be associated with an increased risk of pregnancy loss. So moving away from genetics, there can be anatomical causes, and this is a picture of a uterus. The uterus will house the pregnancy, hopefully for the 9 months of pregnancy. But if there's any kind of abnormality that an individual is either born with, such as, for example, a septum or a wall dividing the uterus in half, or something that is developed later in life, like polyps, fibroids, scar tissue, or adhesions, that can actually be associated with pregnancy loss or recurrent pregnancy loss. The uterine abnormalities that someone can be born with are seen in about 12% of RPL, and typically they lead to later, meaning more second trimester losses. Fibroids and polyps, whether exactly they have a very significant association with RPL and whether their correction leads to significant improvement in chance of success isn't very well understood, but it's something that that is worth exploring for sure. And the way to diagnose these abnormalities is via ultrasound, a special kind of ultrasound called the saline ultrasound or SIS, the HSG or fallopian tube test, or an MRI. Another category of causes is hormonal or endocrine causes. So because the thyroid gland controls metabolism in our bodies, it can also control and help regulate the reproductive system. So if it's running very low or very high in terms of thyroid hormones, your body may sense this as not an ideal time to also carry a pregnancy, and the reproductive system can thus be affected, leading to early pregnancy loss or RPL. Another situation would be having abnormally high prolactin levels. Similar mechanism, metabolically and hormonally, it is not an ideal environment for pregnancy to continue. And then any kind of chronic medical problem like diabetes, prediabetes, insulin resistance, such as seen in a condition called PCOS or polycystic ovary syndrome, where just your body is not, these hormonal or endocrine factors are not well controlled, and therefore they can contribute to pregnancy loss or RPL. The next category of causes of RPL are immune or blood clotting causes. And there is a condition called antiphospholipid syndrome that you may be familiar with. It is seen in about 15% of RPL patients. And I completely understand this is not a medical school lecture, nor do I want us to go into this slide in great detail. But I also want us to appreciate how many factors go into the definition of antiphospholipid syndrome. So having one finding or one abnormal value at one point in time, or borderline abnormal value that is not then repeated, does not fully define antiphospholipid syndrome. And it's important to make sure that we've established the diagnosis correctly, because the intervention that we'll talk about in a minute, which is blood thinners, comes with its own set of risks. So we need to be certain about the diagnosis before implementing treatment. In addition to antiphospholipid syndrome, there can be inherited thrombophilias, meaning I was born with a condition that predisposes me to forming blood clots. And this is not something that is commonly encountered and should only be tested for in patients who either themselves have had a personal history of a blood clot, not after you broke your leg or you were on birth control pills, just unprovoked blood clot, or somebody in your family, a first-degree relative, has been diagnosed with one of these conditions, because it is a pretty infrequent finding, and to just screen everyone indiscriminately for these conditions doesn't make a lot of sense. Of course, I think this presentation would not be complete without these very important factors. And maybe this should have been my first slide, because the importance of this is very high, and lifestyle and environmental factors affect everything we do and our health overall. So smoking, alcohol, weight changes such as obesity or extreme underweight, excessive caffeine intake, environmental exposures, poor sleep, all of those things can truly affect our ability to carry a healthy pregnancy to term, and therefore can increase the risk of RPL. For environmental exposures, I'm specifically referring to air pollution, heavy metals like lead, mercury, organic solvents, some pesticides. There's also endocrine disrupting chemicals, things that you may have heard about like BPA or phthalates, and these actually interfere with the endocrinology of our brain and can affect reproduction as well. Having interrupted or short amounts of sleep, working shift work or chronic insomnia, any change in our circadian rhythm or biological clock can actually affect the reproductive system as well. Now, this is not meant to have us panic about the one time we were exposed to something or the 2 nights that we didn't sleep well, but chronic excessive exposure to these factors can increase our risk of RPL. All of that being said, it is very important to keep in mind and oftentimes very difficult to come to terms with, because obviously you come to the doctor to get an answer. But in 50 to 70% of RPL cases, the cause remains unknown. So we do all of this evaluation and we still do not have an answer. But the silver lining here, or the positive part of this equation, is that still many people go on to have a healthy baby. And this is not just some generic positive thinking. It's actually based on multiple studies, and I don't purposefully have a lot of rigorous scientific slides or data here, but this is a study, and there have been many more since and before that, where each one of these lines, the different colors, represent the number patients who have presented with any number of previous miscarriages. So going from red all the way to green, these patients had had from 3 up to 6 or more miscarriages by the time they presented to the doctor. Then they had testing that showed none of these factors that we talked about were present. Their testing was negative. And then this study then followed these patients over a number of years and figured out what percentage of them conceived. And for patients with 3 miscarriages, the likelihood of having a live birth was up to 75%. I know it's not 100%, but it is significantly higher than you may be thinking, being somebody who has already experienced 3 miscarriages. Even in the green line, patients who have had 6 or more miscarriages are close to 60% chance of having a live birth, not just another pregnancy, a live birth in the follow-up period that this study has looked at, and many other studies have confirmed since then. So again, some positive information there. So once we've done this evaluation, where can we go from there? So there is some medical and surgical treatments we can consider if there is some sort of anatomical or uterine issue. It can be corrected surgically in most cases through hysteroscopy or laparoscopy. These are surgeries either through the vagina or through the belly button, through the abdomen. And then if anything else is identified that can be addressed medically, possible treatments include correcting the thyroid or prolactin abnormality with replacement, diabetes control, treating the PCOS or insulin resistance that we mentioned earlier, and in the setting of antiphospholipid syndrome, using blood thinners, such as heparin, etc., or Lovenox. In terms of lifestyle adjustments, also important. These are some of the things, and when we're dealing with something very difficult, sometimes taking back a little bit of control can go a long way. And some of these factors, of course, not everything is under our control, but some of these lifestyle adjustments can happen a little bit more easily than control of a complicated medical problem. So maintain a healthy weight as much as this is feasible. Quitting smoking, limiting alcohol and caffeine, and in general, and first of all, very important to note that all of these adjustments refer to both partners in a relationship, assuming there is an egg and a sperm source. So because again, there's a contribution from egg and sperm, and important to keep that in mind throughout this information. In general, decreasing alcohol to less than 3 drinks a week or so. Caffeine, ideally no more than 2 cups a day or 200 milligrams a day. Keep in mind that caffeine is not just through coffee. It can be through tea, through chocolate, many other sources as well. So keep that in mind and add it up collectively. Soda, of course. And when possible, try to maybe use glass or stainless steel when storing your food, or picking organic or low pesticide foods. or avoid synthetic fragrances. And then in terms of sleep, minimize light exposure at night, i.e. avoid cell phone use around the time of sleep, and prioritize around 7 to 8 hours of sleep, quality sleep a night. And I said earlier that may give us back some control in terms of the few things we can control, but it shouldn't become these unachievable goals that we are setting for ourselves and are giving us more stress and making this process harder. So something to keep in mind, but definitely not the only thing that is important. In terms of fertility treatments that can make it, that we have available to offer, we have baby aspirin and progesterone supplementation. So if you've done any kind of research or reading or have seen a physician about RPL or pregnancy loss, this is something that may come up. And it's controversial that I have this on my slides because very well designed large clinical studies have shown that these two modalities together do not improve the chances of success in a subsequent pregnancy, overall, statistically speaking, but clinically speaking, I tell my patients that since they are pretty low cost and pretty low intervention treatments, if you're willing to give them a try, I would support you because there may be some benefit in your particular case. By baby aspirin, I mean taking a daily aspirin 81 milligram over the counter. And by progesterone supplementation, I mean in the second half of the cycle after ovulation, using vaginal suppositories of progesterone to support the natural progesterone that rises in the second half of the cycle anyways. And of course, there is, this is a fertility center, and there are some options or some treatment options through IVF if we are dealing with a translocation. Again, this is the chromosomal abnormality in typically one, very unusually both of the parents. Then chromosomal test, going through IVF, creating embryos to chromosomally test them. That's what PGT stands for, pre-implantation genetic testing. So chromosomally testing an embryo open, it does not carry the chromosomal rearrangement that the parent carries, and again, the majority of their cells, can be very useful. In the case of randomly looking for a chromosomal abnormality in the embryo for the first time, those aneuploidies or trisomies that we talked about, there is a different kind of chromosomal testing that can be performed that doesn't necessarily make a significant difference in every case of RPL, but it's absolutely something to consider and discuss with your physician about and get more information on that. Very, very important, again, going along the lines of what we have discussed already, and probably one of the most important take-home points. Self-care is extremely important through this process. It is very important to support yourself, each other in the partnership, and try and minimize self-blame. You did nothing wrong to cause this. Give yourself the grace to deal with this process. Give yourself permission and time to mourn and seek support. This is pregnancy loss is loss. And loss leads to grief, and grief is normal and valid, and you deserve to grieve, and you deserve to take the time to have bad days and good days, and just normalize your emotions and feel comfortable around them. And because the emotional toll of this can be very intense. And we also know that chronic stress, even though I said in the beginning, no lifestyle or chronic stress factor can single-handedly cause a miscarriage, it is important to know that excessive chronic stress can actually change things hormonally and metabolically in your body and make it less likely to conceive. But of course, this can become a vicious cycle of I have losses and I get stressed out, and that leads to more losses. So it's important to seek appropriate support and to minimize self-blame. You're already, by asking these questions that you're asking yourself, you're already doing the most important part of this process, and you deserve the grace that you're giving yourself and allowing time to grieve through this process. Okay, so what's next? So now that we got a little bit of an idea of what pregnancy loss or RPL entails, we have the option to schedule a consultation, and this can be with your GYN, your infertility specialist, but through the Johns Hopkins Recurrent Pregnancy Loss Center, we will have an initial consultation where we will go over comprehensive history for both partners, if applicable. We'll talk about many possible factors that could be contributing, and then optimize preconception care. That's extremely important because we don't just want to blindly get into another pregnancy that may result in loss without optimizing our preconception care. So making sure we're set up for success, and then discussing testing and treatment options as our next steps. The Johns Hopkins Fertility Center, it's located at the Green Springs Station in Lutherville, just north of Towson. And we also have a satellite location in Columbia, Maryland, in Howard County. There is a picture of our building here. Everything is located on the 4th floor of Pavilion 1 in Green Springs Station. And we have our consultation offices, embryology, andrology laboratories, the IVF center, and as outpatient surgical center for some of the procedures that I mentioned. Testing happens there, and this is the number you call to make an appointment. Specifically, the Multidisciplinary RPL Center at Hopkins has been a very special passion of mine. At our center, we take a very holistic, patient-centered approach to RPL diagnosis and treatment. We try to be as inclusive and as holistic and integrative as possible. The team of experts that we collaborate with include, obviously, reproductive endocrinology and infertility. This is what my specialty is. Maternal fetal medicine, these are the high-risk obstetricians that typically follow a pregnancy in the setting of I previously had recurrent pregnancy loss and I'm now pregnant, because that can oftentimes be a high-risk pregnancy. Endocrinology, diabetes, and metabolism, this is the specialty that deals with the thyroid, prolactin, diabetes components of RPL. Genetic counseling in the setting of any kind of chromosomal abnormalities for the embryos or parents. Hematology in terms of antiphospholipid syndrome, rheumatology, and of course, I'm just mentioning these are not the only applications, but just mentioning some highlights here. Rheumatology in terms of lupus or other autoimmune conditions that can contribute to RPL. Psychology and mental health, as I talked about and tried to stress, and I hope I emphasize this enough, supporting you emotionally through this very difficult process. Urology, extremely important to have the reproductive urology standpoint for sperm contribution to this process. Again, not as much is understood or studied when it comes to sperm as we know about eggs, but still considering all those factors is very, very important. And healthy weight management in terms of one of the lifestyle modifications that we can help support patients through. We also have the opportunity to have our patients participate in cutting-edge diagnostic approaches, so testing modalities and clinical trials that are taking place at Hopkins through multi-center collaborations. Okay, I'm getting towards the end, so thank you for hanging in there. Some important, at least to me, key points to take away from this is RPL is more common than most people realize. And I'm not saying this as a positive, but I'm saying this as you are not alone. It is frequent. You are not the only person who is experiencing this. There is support. Many causes are treatable. And with support and care, most people eventually succeed even when a cause has not been identified and no specific treatment has been implemented. You definitely deserve compassion and answers. And please remember, again, it is not your fault. You are not alone, and there is hope. And I'm including this picture of a rainbow baby, and rainbow babies are typically babies that are born at the end of a RPL or pregnancy loss journey, and there's always a rain of sunshine at the end of every rainstorm. I think these are all the slides that I had. I will leave it here so you know how to send us some questions, even though I would like to leave it in the previous slide with a rainbow baby. I have a question already, so and please feel free to submit them in the chat anonymously, and I will read them out and answer them. So we have a question. What are your thoughts on Clomid letrozole for luteal phase defect, low progesterone causing recurrent miscarriage? Okay, so I purposefully did not write out in my slides luteal phase defect because it is a little bit of a controversial topic. Yes, some studies suggest, and remember what I said in the very beginning, there's a lot of gray area in this field, unfortunately, and luteal phase defect is not a very well supported by data factor contributing to pregnancy loss or RPL. However, understanding or accepting that there is definitely some truth there, that's where my recommendation for the progesterone supplementation that I talked about was based on or trying to address. Now, Clomid and letrozole are a little bit different because Clomid and letrozole can help with ovulation induction. So if you're either having trouble ovulating on your own, or if you're ovulating on your own, but you need a little bit of further support to increase your chances of pregnancy per cycle, we can definitely use Clomid or letrozole, but they themselves do not necessarily take care of any issues with progesterone in the second half of the cycle, and therefore I would prioritize progesterone supplementation if we even want to go there. You know, if discussing with your physician, it appears this is a good approach for you. And secondarily, Clomid and letrozole. There's nothing wrong with them, but them alone will not help us with progesterone support in the second half of the cycle. I oftentimes use them together with progesterone to help with that support that we need. Does very strong data exist to support its use in preventing miscarriage or RPL? Again, no, but as an intervention, it's pretty minimal for most patients and doable, and therefore I do recommend it. Or at least I do discuss it with my patients. I don't see another question. It's possible. Oh, okay. Great. I see that question. Oh, sorry. There is another one. Sorry, I wasn't scrolling. I'm not that technologically advanced. Okay. What do you think about using hormonal birth control in the past? Does it matter if it was estrogen or progesterone based? So we do not have strong data or truly any data to support that having used birth control pills, hormonal birth control in the past for any amount of time, whether it was estrogen and progesterone, progesterone only, leads to a higher risk of pregnancy loss or miscarriage or RPL in the future. If anything, once you discontinue use of a birth control method like that, oh, I'm sorry. I scrolled into the second question and I got confused. I'm sorry. So if anything, when you discontinue hormonal birth control, it may or may not take some time to resume regular cycles or ovulation, but then you should go back to normal, and your normal chances, what your chances would have been for a healthy pregnancy or miscarriage without any effect from the previous hormonal contraception. The next question, sorry, that got me confused because I scrolled down too far, was what about using birth control after having recurrent pregnancy loss, even though I've had a baby and might want another in the future? I am not sure I'm understanding the question 100%. Again, maybe I've answered this already, if maybe I'm misunderstanding the question, but I've had recurrent pregnancy loss, or I haven't had recurrent pregnancy loss, I just have used hormonal birth control, should not affect my chance of miscarriage, either as I'm starting my family building or if I've already had miscarriages or RPL. I hope I'm understanding this question correctly. If I'm not, please rephrase. And next question is, how many cycles of letrozole would you recommend? It depends on what we are treating exactly with letrozole. Letrozole specifically for RPL, it depends on exactly what we're trying to accomplish. So letrozole in and of itself does not change the chance of a pregnancy loss, of a miscarriage. It makes it more likely, it increases the chance of conception per cycle in the setting of helping with ovulation, but it does not change the outcome of the pregnancy. That being said, if letrozole is used in the setting, for example, of PCOS or somebody who doesn't ovulate regularly and letrozole helps them ovulate, it is appropriate to do multiple cycles of letrozole, as long as that person does respond to it with, by response, I mean ovulation does occur. There's no specific number. You may be referring to maybe the three cycles of Clomid or IUI, which is something we encounter a little bit more in a slightly separate topic, that of unexplained infertility. And again, not so relevant in the setting of RPL, but if we're talking specifically about ovulation induction and helping someone ovulate who doesn't ovulate on their own, multiple cycles of letrozole can be beneficial. Obviously, taking many other factors into consideration, assuming fallopian tubes are open, uterus looks normal, semen parameters are normal, and age is not a significant concern weighing in on the repeated cycles. Okay, there is another question that says, does inflammation in the uterus cause pregnancy loss? And that's the very short answer is yes. The expanded answer is, how much time do you have? And what I mean by that is inflammation in the uterus. How is this defined? How is this tested, diagnosed, and treated? Inflammation in the uterus, in the pelvis, in your body in general can definitely be associated with miscarriage or RPL. Correcting the inflammation is addressing the source of the inflammation and correcting it, if possible, definitely makes sense to improve our chances of next pregnancy going to term and having a healthy outcome. But that's unfortunately where not everything is very well understood or defined, and that's where a multidisciplinary approach with some of our colleagues in hematology or rheumatology and some other specialties can truly offer very valuable insight in the management of these patients, along with some of the specialized testing that I mentioned that we offer at the RPL Center at Hopkins. Another question that I see is if in my facilitators, if I'm doing this incorrectly, please let me know. Okay, if we have an appointment with you about 6 weeks from now, is there any reason to wait to start until we see you to start taking 81 milligrams of baby aspirin? Would it be okay to start now? So I look forward to meeting you. And in terms of starting baby aspirin now versus after you meet with me, assuming there's no major contraindications in your own personal history, which typically most patients do not have, but I would check with your PCP if that's an option. But starting a baby aspirin and taking it once a day would not, regardless of phase of the cycle where you are in your menstrual cycle, would not be a bad idea. Is it truly helping you in particular? It is impossible for me to tell because I don't know what your underlying cause of RPL is, but it's something that we can definitely would not hurt to attempt. Another question that I see is there any way that I can help prevent miscarriage once pregnancy has been confirmed? Unfortunately, there isn't a well-established way to do that. What we do offer, amongst other things, at the Fertility Center and specifically the RPL Center, is very close and early monitoring of pregnancy so that we can get as much information as possible as early on as possible. And of course, we work with patients and figure out, excuse me, we figure out what makes most sense. Do you want more information? Can you benefit from it? Does it help you in this process, or is more information more harmful to you? So we work together to figure out what makes most sense for you in those early, very nerve-wracking and stressful stages of pregnancy. But unfortunately, the goal of that is for information and monitoring, not so that we can say, oh, here is what I'm noticing, here's what you can then do to change your chances. Unfortunately, there is very little that we can do once an early pregnancy is progressing into a miscarriage to prevent that from happening. The next question that I see is, I am a 31-year-old female and have had 3 miscarriages in the last 7 months due to embryo having chromosomal abnormalities. I'm very sorry to hear that. In your experience, is there a certain number of miscarriages or age that affect whether or not insurance will cover IVF due to miscarriages and not due to infertility? So, unfortunately, I don't have a clear answer on this because it completely depends on your insurance company, your insurance plan, and what exactly it involves. What I mean by that is, from the very little that I'm understanding from this question, without, of course, having met with you, again, I'm very sorry. I can't imagine how emotionally difficult this must have been. But I assume that at least one of the diagnoses in the for the consultation and then subsequent treatment, if IVF is decided upon, will be RPL. And RPL and IVF with chromosomal testing of embryos in the setting of RPL should logically, of course, be covered by insurance. Whether your particular insurance covers it or not, it is impossible for me to tell. If there is coverage for IVF and there isn't coverage for chromosomal testing, which isn't rarely the case, unfortunately, or if IVF coverage is not provided yet, maybe insurance is making you try another treatment first, I think myself for sure and my colleagues would be very happy to provide additional documentation to the insurance and say, this is why this particular treatment is important or recommended for this individual, and that's why we are supporting this recommendation. And sometimes insurance will understand that and provide coverage. Sometimes that will not change the outcome, unfortunately, but to learn more about the specifics of your coverage, I would recommend you either call your insurance directly and or if you were to call the office and schedule an appointment, this is something that our financial counselors can provide information on. Okay, next question is, what testing would you recommend for someone who has miscarriages or lack of heartbeat at the same gestation every time? Again, I'm very sorry if this is something that you have experienced. I would probably be referring to a lot of the things we already talked about today. And true to the slide where I talked about a comprehensive history taking, I, of course, cannot make a single recommendation based on this amount of information. So I want us to either with myself or any other provider that you feel comfortable with in REI, in OBGYN, just have a very thorough evaluation of many factors: ages, previous pregnancies, other health factors, family history. Understand everything about yourself and your partner, if that's applicable, and then decide what kind of testing is appropriate. I tend to err on the side of more testing because the counter argument would be, this isn't important enough, we're not going to test for everything. We may test after your next loss, right? And nobody wants to have you go through that. So asking more questions up front gives us more tools to be able to address some of those issues. But again, back to something we said several times, we may not have a crystal clear answer that lets us know how exactly what our next course of action should be. So I know I didn't answer your question, but it would have to be specific to many more pieces of information from your history and that of your partner, if you have one, to be able to determine what testing is recommended. But it would be essentially the pool to choose from would be everything we talked about today, and what specifically applies to you would be dependent on your own history. I believe I have answered. These are the questions that I'm seeing here.
Are there any other questions that anybody has? If not, we'll probably wrap up early. Thank you to Dr. Maragiani for jumping on for this. And then if you have any other questions, you can always call the Fertility Center or reach out to Hopkins Seminars at jhmi.edu. Have a
Thank
lovely
you all
day.
for attending. Have a good night.